start us out.
Just a question as to if any corrections officers have been trained. I've done some consultation to facilities where corrections officers have been the one that pushed for DBT. And they're the ones who have found themselves needing to coach the inmates. They both found themselves needing to coach them, and the ones writing up the disciplinary tickets that resulted in longer lengths of stay. And so they were so disturbed by having 18-year-old kids coming in for a 6-month bid, ending up with a 10-year length of stay because of excessive violence, that they actually started implementing DBT, teaching skills, and coaching. So just because officers aren't trained in the facility doesn't mean that they can't be very important pieces of the milieu treatment. And we're doing work in the Juvenile Corrections Department in New York State, Andre and I, and we are training the line staff who must maintain care, custody, and control to actually offer coaching simultaneously as well, so that there is a way to kind of dialectically synthesize the two. So
I think there's good evidence out there at this point that in terms of teaching skills training and milieu interventions, that it doesn't I think it's some good evidence out there that in terms of teaching milieu interventions and skills training, that you don't have to have a master's degree. There's a Houghton and Singh article that's been out for quite a while now that talks about bachelor's level interventionists who are trained to be able to do DBT with fidelity, particularly in carrying out skills training and milieu interventions. And the state of Washington, which was the largest single implementation with the Washington State Juvenile Rehabilitation Administration, used DBT as its primary mode of treatment with 800 incarcerated youth, and trained its line staff. And that's been written up in Blueprints for Change and is one of the promising evidence-based treatments for work with institutionalized youth.
I mean, it's not hard.
We have a question about DBT's effectiveness for antisocial personality. Can DBT still be effective with antisocial personality? I'm also going to extend that to the start now as well. And in general, if our other panelists have things that they can offer with regard to this question.
Well, to my knowledge, we do not have careful studies with antisocial personality disorder looking at the outcomes. I have only anecdotal experience. And it's mixed. It depends on the individual more than anything else. Because the kid who had conduct disorder, who grew up to be an adult with antisocial personality disorder, has a history. And whether they are interested in a future can really determine whether or not they're interested in making changes. There are some who are, and particularly, one of the fascinating things, and it requires of us to actually be clinicians, to actually sit down with another person and understand what motivates them. So many have no hope for the future. They live day to day and they expect to die young, violently. And so, if that's the expectation, why should they change? If, however, there is the sense of hope that something could change and that it's within their power to begin that process, then I've seen individuals who have an antisocial personality diagnosis participate meaningfully in therapy. Not to simply become, in the minds of some individuals, better at being psychopathic, but rather better people. There's a separate issue which goes much more to psychopathy than to ASPD, and that's still another topic. There's some work being done in Holland by Corinne de Ruyter and by David Bernstein using schema-focused therapy that has shown promise working with people with antisocial PD. But I'm not aware of any specifically with DBT, and I defer to Andre for that.
There are no controlled studies, but I really liked something, I'd like to highlight something you said, because this is the second time in a couple of weeks I've heard exactly the same comment. This is a tiny bit of field, but bear with me. I heard a very profound lecture a couple of weeks ago by the head of the sex offender treatment program in the Federal Bureau of Prisons, and went through all of the things that we know about sex offense, what we know about people who commit sex offenses, and what we know about trying to treat them, and came down to, at the end of it, saying we really have to individually assess each person in his or her environment. And it was an argument for idiographic assessment of the sort that the chain analysis does, and of the sort that DBT says you have to do with every individual who comes in if you want to figure out what their targets are, what their goals are. And I think more and more when you're talking about these very complex and difficult populations, I think we're coming full circle. There is not a one-size-fits-all package. And I think that's why principle-driven treatments are showing better results than manualized treatments. So when it's not a one-size, this is what we're doing this session, this is what we're doing next session, this is what we're doing the session after that, where it is tailored to the individual and there is some sense of this is what this person needs. Anyway, that's...
We have a number of questions that have come in related to youth, and I'll start with this one. Can anyone comment on older child adoption, such as, an older child adoption related to reactive attachment disorder and BPD diagnosed in adolescence? Related questions had to do with issues such as violence of adolescents against family, leading to DCF investigations, Department of Children and Family Services investigations or criminal charges. Can anyone comment on these sorts of youth legal involvement? And dealing with that, and part of this context here is we have a variety, we have clinicians, we have family members, et cetera. Does any of this, we've been hearing a lot about kind of adults in legal, and we didn't have a speaker specifically on this issue. Can anyone comment on anything we know about working with youth with behaviors that may include aggression or legal issues?
So this is, again, anecdotal, and it's based on the classes that I've taught. Nothing is more burdensome to a family than having a child who has suicidal tendencies. But nothing is more shameful than having a child who is violent towards his or her parents. And that shame often encourages parents to actually stay silent and not get the help that they need until, a lot of violence has actually been committed and the situation is pretty bad. Oftentimes, when those parents join our groups, it's really hard to sort of bring them back to the level that other parents are, if you can believe it. So their level of burden and stress is that much greater. A lot of our sessions are actually focused on trying to give parents a sense that, it's that healthy selfishness I was talking about, give them a sense that not everything is acceptable and that there are certain limits that absolutely cannot, be played with or gone beyond. And so a lot of the work is done around that while trying to work with their violent teenager. The idea is to try to get the teenager in treatment. I mean, this is not something that parents can deal with, but if they can manage to help their child get into treatment, then oftentimes the family is a huge step ahead. So that's the advocacy that I have.
I work with a lot of parents, or maybe not a lot, but one of the things I really like to do is working with parents who would label their children as out of control. I've gotten a lot of parents who are just kind of exhausted over time by having treated chronically suicidal or aggressive kids who are now young adults. And there's important lessons to learn from them. I think there is this idea of, well, what do we have? Our child doesn't really fit any easily kind of checkboxed criteria, so they're diagnosed kind of late. They don't get specific help that they need. Kind of parents are flying by the seat of their pants. It is shameful, it is difficult, but the other thing that I see in a lot of the environments where I am at is that parents have actually tried to mitigate consequences. Because it's so shameful, they bury it, and then they will kind of brush over things. They will not really debrief in a very big way. We all hope that it's going to be over and it's not going to happen again. The root causes of the escalations either get blamed on one person or another. It's not seen as transactional. It's not seen as kind of mutually reinforcing behavior. And so we work really hard to think, what are the limits that the parents have? What might be the child's limits? How might we invoke consequences, again, to stop that behavior? How we really work to get treatment up front. Sometimes I use the legal system for help. The buck stops here. You cannot set fire to your parents' house. You cannot any longer steal every shred of credit card, every paper, every bank account number. You can't do these things. There is a consequence for it. So the idea is really getting the parents' support. The other thing is attachment difficulties, either antisocial or borderline personality disorder in the transaction of the home, make for moving somebody from kind of despair to change through the relationship with the therapeutic provider difficult. It's difficult for, if you want to call the client, the child to be engaged, and even more difficult to get them engaged when they're in secure settings or prison settings or jail settings. So that's another obstacle to working, I think, with people with ASPD in the end, that it takes a long time to form trust, a long time to figure out that you're not going to try to harm them or get one over on them. And oftentimes, as I said, they haven't been taught empathy, they don't know reciprocation, they don't know a lot of those things. And I think that's true in these families where you have the out-of-control kids at the younger ages as well. So concentrating on all of those things with the kids who are out of control, the parents who have kids who are out of control, and then later people who are in incarcerated settings, I think all of those foci for bringing your attention are really important.
There's a question about getting the advice, don't take it personally, still on the same topic. How does one achieve this? Is there anything that anyone want to add, kind of a focused suggestion on how a parent can avoid taking it personally with attack from, verbal attack from child? Anything additional to add?
Earlier I was talking about little mantras like benign, benign, benign. There is a mantra that we share, which is curiosity and interest are the opposite of anger and contempt. And if you can keep that in your mind, curiosity and interest, it's really hard to be curious and to be angry at the same time. It's really hard to truly be angry and smile. So if as a parent, instead of, and it's totally normal that you would get angry. That's what we do as parents. We mirror our children or our relatives' behaviors. If in that moment, instead of mirroring the behavior, you can sort of go, what's going on here? Then you win, because that's the curiosity. My personal mantra, which works better for me, but apparently the other one works better for more people, is what am I missing? So if I see my daughter get really angry, if I ask myself, what am I missing? Then in that moment, I get curious. I'm wondering what's going on. And it allows me to sort of stay at baseline. So I'm hoping that this responds to the question.
I didn't talk about this research today, but there is another line of research in which I'm coding, my research team is coding the interpersonal behaviors of parent-child dyads and looking at the stress response and looking at what kind of synchrony between different behaviors are related to increased stress response. And remember I was talking about hostility being kind of the key component to a lot of this. And when you watch the videotapes, and these are not adolescents with BPD, they're adolescents at risk for various reasons, but there are also a lot of healthy adolescents. And when you watch the videotapes, it's a conflict discussion, and you see either the parent or the child becomes hostile all of a sudden. And then you see the other individual drawn in. So to kind of go to what you were saying, you kind of see it reciprocated, right? And it's very easy to be pulled into that because a lot of the social processes say that if someone's hostile to you, you're going to be hostile back. Like you're pulled to do that. And so I think exactly what you were saying is that taking a moment and recognizing, okay, this is a hostile behavior. This is going to, if you continue to engage in the process, both of you are going to have high stress responses physiologically. When you have a high stress response, it activates the amygdala. So we saw all kinds of things about the amygdala today. And it shuts down the prefrontal area that's regulating and thinking deeper about it. So you don't want to encourage the stress response, and you want to refrain from engaging in the hostile responses. However, whatever mantras you might use or interventions, it's really interesting to see on tapes, videotapes that are coded in another process as being good parents, how the kid might get a little snippy and start talking back because they're talking about conflict things like, why didn't you clean up your room? Why didn't you put the clean clothes away? And the kid might talk back, and the parent that tells them, okay, this is your job, but does it in a really affiliated way, you see the entire interaction kind of calm down and re-regulate. So I think that, we're talking about very different processes. These are kids that don't have conduct disorder, don't have early signs of having a diagnosis of BPD, but probably if you're capable of engaging in it, it might really help both of you.
One last question, sort of in this vein perhaps, is it possible to determine if a patient with BPD believes the lies, distortions, versions of what he or she says, or if he or she is aware she is lying, distorting? How is this assessed? And this was also in the context of an adolescent. Any recommendations, suggestions on that distinction, whether the individual is aware that they're distorting or they believe what they're saying?
I think this is a good opportunity to use dialectical thinking here, right? It's a good opportunity to use dialectical thinking where in the moment they might see something as one way, really strongly the way they interpret it. And as we talk about emotions, there are prompting events and then there are interpretations, and then the interpretations help kind of flow the rest of the cascade of the internal response and the action out. And so if you can really work hard on the interpretation, is this the best interpretation? Is this the only interpretation? Again, could you come up with 10 others? Could you think something, now that you've thought about more things, which do you think carries the greater weight? Did that thing you think in the beginning, does it still grip you with this 100% certainty, that you thought in the beginning? And usually I find when I go through that exercise formally enough, people will say to me, oh yeah, I did that circle thing and it went from an 80 to a 20, something like that. And so I do think they believe it in the beginning. It's the best they have. Their interpretations, their phenomenologic, contact with the world, that's what they get, but it doesn't mean that that's what they should stick with in terms of being effective. And so how closely they hold on to that interpretation is a way for you to figure out how much work you have with them, I think.
Does saving a patient from stigma justify withholding an official BPD diagnosis even when the patient meets diagnostic criteria? Anyone wish to comment on that? I think everyone heard that? No? Okay. This one is a follow-up on Dr. Ansel's talk. Do the same affiliative misperceptions occur when the person with BPD is observing others interacting socially as when the person with BPD is one of the interactants?
Well, it was not done as part of that study. Or it could be, so they did misperceive their partners, the guy that they're interacting with. They misperceived his behavior. But when they're not part of the interaction, did they misperceive? I don't know that that study's been done. It's a really great idea.
Excellent. We have a question. How do you suggest a clinician, not the prescriber, discuss placebo effect or limited effect of medication? So perhaps that we'll start with Dr. Denise, but anyone might comment.
Delicately. Delicately, I said. Again, I think it just gets back to if we're all reading literature about, the illnesses that we're treating and the interventions that are out there, I don't think it's a surprise that these medications have a limited benefit. The question is, to what extent is the conversation happening between the patient and the person who's prescribing it? In DBT, we consult to the patient, or you consult to the client, and so you would do a lot of work. The therapist who's not the prescriber would do a lot of work around, well, what's your understanding, and what's the benefit, and what are the side effects, and how long have you been on it, and do you really know? What was the initial indication that you were put on it for, and now why are you still on it 5 years later? Those questions bear asking, as does, is this treatment working for you? What are the indices we're looking at? Are there any observable data to show that DBT is currently being given, or whatever therapy is helpful to you? Are we doing what feels good, or are we doing something that actually is making a difference in your life? Those same sets of questions, I think, should get asked of all the interventions that we dish on people, not just medication. But so I think it would be a very familiar conversation no matter what intervention is being offered.
A couple of days ago, I was giving a lecture to second-year psychiatry residents, and much of it had to do with exactly this kind of topic about, and I do want to apologize to the person who asked the question before about, do you share with people the diagnosis and the stigma issue? Because, my sense is you do, but part of it is how you do it, and that also informs the treatment. Because all too often when I see someone with a diagnosis of borderline personality disorder, they will be, if they're lucky, on only 3 medications. And it's frequently a pharmacopoeia of stuff. And they don't know why. And the treater is so frustrated frequently that they've lost track. They're just, the pragmatics of healthcare in the community right now are such that you start someone on a medication and it's helping some, but not perfectly. So you add another one because you don't want to take the risk of taking them off of the other one, destabilizing them and getting them hospitalized. So they're sort of okay, you want to help them get better, so you can construct in your mind, well, maybe I should just add this one. And that happens repeatedly, and no one takes anything off. And so you've got this potpourri of medications, many of which are subtherapeutic and are only exposing people to side effects without the potential for benefit. Now, that goes actually back to the other question about diagnosis, because the real issue is why are you on any given medication, which is part, as Paula mentioned before, informed consent. Informed consent doesn't only mean what side effects you're exposing yourself to, but why were you on the medication in the first place? We don't have medications to treat borderline personality disorder. Full stop. We have medications that have some limited benefit in treating some of the symptom clusters of borderline personality disorder. And so it's very important to be in agreement with your patient about what the symptoms are, that they are in agreement with it, and that they are in agreement that it's a problem for them, and that they're willing to take medication in a way that is structured with observable, measurable outcomes that you and your patient objectively create, so that you can actually see if it's helping or not. And if this medication magically gets the symptoms gone in 24 hours, it is magic, and it's not likely due to the medication, other than the perception that the medicine is going to work. And I I don't want to minimize the placebo effect. It's best for acute issues, but for chronic challenges, it's not something we can rely on.
Just to go back to the stigma and the diagnosis, I think we get this question a lot at this conference about how to deal with telling someone their diagnosis when there is a potential stigma. But I think there's a very easy answer to that, and that is this individual has come to you for treatment for X symptoms, right? And they've talked to you about what their problems are, and they've probably articulated them or heard them articulated to them by people in their immediate life, their significant others. And if you put out a description or you just give them the symptoms of BPD and ask them, do you feel like this reflects what you've been telling me? Because you've told me about your impulsive behaviors, you've told me about how angry you get, you've told me about the problems you're having with these important other people in your life, and you've told me about how you think about harming yourself. And they will say, yeah, that totally fits, yeah, exactly, right there. And a lot of times that's really a mirroring experience, and it's not necessarily a stigmatizing experience. I think the stigma comes from everyone else in the world, and not necessarily from the diagnosis itself. So I think helping patients cope with everyone else in the world is one of our jobs as therapists, and how everyone else views them and responds to them. And that's another issue that I think just the diagnosis itself.
I just got to add a bit to that. All too often, it's us who has the stigma of the illness, and we convey that to our patients. By not naming it, we give it the power, a magical power of stigma. We make it worse than it really is. But by going through the criteria, and through that kind of a mirroring exercise, from what you've told me, you meet these criteria, yeah, absolutely. And for shorthand, we describe that cluster of problems as borderline personality disorder. Over the last 20-odd years, I've done this a whole lot. And people are generally relieved when they can sit with someone who can honestly, calmly, and thoughtfully give them an understanding of what the problems are in the context of a diagnosis, especially now, where the results of so many long-term trials are demonstrating treatment works. It's not immediate, but over time, people will recover. And that really is changing the context and the value of being open, direct, and honest with your people, with your patient.
One more thing, and I think that the next step is, certainly in DBT, but I think if you look across most evidence-based treatments, you will see the next step after that is, where does it come from? And in DBT, that's the explanation of the biosocial model, which adds context, and it's an explanation, which is what's wanted after that identification of what the phenomenon, what the diagnosis is. And I think that whole psycho-ed piece is one of the first steps in any evidence-based practice that's out there.
Continue with that. Is there a distinction between an invalidating environment, part of the biosocial model, and an aversive one when it comes to prison populations? Or more generally, are those different?
I think that most people in a correctional setting can easily acknowledge and accept that it's aversive by design. That said, individuals respond differently to an aversive environment. Some of them seeing it as demoralizing, some of it seen as undercutting their sense of self-worth, and others seeing it as potentially punishment, but also giving them the room to start working on reparation. So it's not intrinsically invalidating. That's the individual response to an aversive environment.
Just to say one more thing, it's that an invalidating environment is personal in many ways, right? It's personally invalidating. And I mean, I've only worked very briefly in forensic settings, but it's not personal, it's everyone. And so I think in that way, then, even if an individual doesn't experience it necessarily as that in the moment. It can be talked about that way too.
I think we need a dialectic here.
Let's leave the microphones on.
Okay. I think we need a dialectic here. I've worked in prisons for probably 8 years and consulted to them, some max prisons. You are a number. You move when you are told to move. You go to the bathroom in public. You have visits taken away. You have your pots and pans taken away when somebody else on another unit fights. And the warden in the middle of taking them all away realizes, oh my God, then we're going to have cooking problems. And then the units that were going to get their pots taken away at the end now have their pots. And the other units that lost their pots, lost their pots. As a staff member, you can't see your people because something else needs to happen. You have crises that interfere with work. Even though you don't want to support crisis-generated behavior, you are forced to. So I think that there are people who have control in prisons in all sorts of surreptitious ways. I think there are the nice officers that really look great that are sexually assaulting women inmates. I think that it is both kind of there for everybody, and maybe you can take it a little less personally, and then it is very personally directed. There is a blue ceiling, there are therapist ceilings, there are all sorts of things, and so I think that if you're already vulnerable to anything, these things are incredibly difficult to manage, and there is not a lot of consolation sometimes. Just that everybody's going through it. No, they don't. They go through it differently. Some people really get singled out. If you are a blubbery, crying person, if you are wearing diapers, if you somehow are gross to people, if you are a pedophile on the bottom, the invalidation you're going to get is personal. On top of, the egalitarian. Just to be dialectical.
Keeping that conversation up, looking at the definition of invalidating, I don't know that it's invalidating as that's individually targeted, and it's typically focused on that individual's behavior. So it's a valid representation from that other individual of how they are behaving or based on what they have actually done or what the word on the street is, as opposed to the kind of classic perception that I'm upset. No, you're not. I'm happy. No, you should be sad. I mean, so it's not invalidating, at least not as I understand it, so much as it is directed and targeted and individual specific.
This question is about whether there's any evidence that DBT or Start Now results in medications being discontinued, and or whether the inmate patient feels meds can be discontinued. Any evidence of that?
There is no evidence in forensic settings to that. I think the evidence that Marsha cited yesterday in her talks was about the study that used treatment by experts and found that in the treatment by experts versus DBT treatment, that those folks were more likely to get off their drugs. So that's...
I would say in my private practice,
Use the mic.
yeah, in my private practice, people come in on many meds, and a part of what I do is stop the polypharmacy. It's time and time and time again. People don't need what they're on, and they're in DBT and they're learning skills, and by the time they leave, some are not on any medication at all, and living productive lives.
I hope within another year to 18 months might be able to look at that kind of data, but we can't right now.
Final question is about follow-up for individuals who receive DBT. This was in context of juveniles, but the question is do they get support? Do they get support from their families? Do we know much about what happens after treatment with regard to continued needs? One thing that I'm going to suggest is, with regards to the families part, whoever asked this and anyone else interested, to really take a look at what National Education Alliance has to offer, because those are becoming, their offerings are increasingly accessible, and specifically to help with family functioning beyond what these treatments themselves do. So I invite people to look at that. I want to thank our panel of discussants again. I want to say a few words and thank you for our panel. I'd like to just invite people to consider again our general goals of the conference in terms of better understanding what is borderline personality disorder, what are these particular kinds of challenges, and also getting ideas of what can be done about it in terms of solutions to help people with the struggles they have. From all of our perspectives, I have a number of highlights that jumped out to me on these issues. I'm not going to go through them just for time's sake. I think we're all a little bit tired, so I'll let those go. I do want to share one announcement which Dr. Tressa mentioned, but I'll say for our entire group, there are no conflicts of interest for any of our speakers with regards to material, financial conflicts with regards to materials presented today. I do want to alert you to the fact that on the National Education Alliance and their advocacy, that a few years back they started doing congressional briefings, and it was in 2008 that the United States House of Representatives passed a resolution declaring that May is Borderline Personality Disorder Awareness Month. So this would be our fourth Borderline Personality Disorder Awareness Month. In the spirit of that, I would invite you all to please talk about what you've heard here today with your friends, with your family members, with your colleagues. Please help spread the word in terms of awareness of borderline, in terms of understanding individuals who struggle with this in order to decrease stigma, and also with regard to all the various innovations we've heard today in terms of psychopharmacology, in terms of treatments applied to in real-world settings. Please share those messages. Thank you very much.